Thank you very much, and thanks for those that are here. So, as it's a small group, it might be quite nice actually to do a little bit of an introduction. I will start. So I'm Julie, and over the last 18 months, I've been leading something called the London Transformation and Learning Collaborative, which you may or may not have heard of, and I'll find out from you in a second if you have. But my role had previously been in health education in England, and my professional background is a nurse, a paediatric nurse, and I've been working in paediatric critical care for a number of years. We've been working within education at both a sort of trust level and then a system level for the last sort of 15 years, really. But I wonder if it would be quite nice actually just to introduce yourselves as well. Like I say, as we're quite a small group, rather than me just talking at you, we can have a bit more of an interactive dialogue. So Catherine.
Unmute myself. I'm Catherine Davis, and I work at the Northern Care Alliance, which is recently formally formed. So I've been in the NHS since 2003. Always in the HR sort of people management field. My current role is workforce transformation lead, so hence obviously my interest in all things that to do with transformation. So it's nice to meet people who I might not have met earlier in the week and to see people I have again.
Lovely. Thanks, Catherine. Tim.
Hi, I'm a GP in Tameside in Greater Manchester. Still work 3 days, and I've got a 1 day a week job with a Hyde PCN, working on anticipatory care in patients with dementia and patients with multimorbidity.
Fabulous, thank you. Sounds quite interesting. I think those are you're the two people that have joined. Is there anybody else?
Oh yeah. So if I go around to Simon.
Unmute myself. My name is Simon Orr. I'm an applied workforce planning lead, one of 3 in the Southeast, working for Health Education England in the transformation team. And I focus on a number of regional wide programs, but because there are 6 systems and 3 of us, we each face 2 systems for everything. And my 2 systems are Bob, Buckinghamshire, Oxfordshire, and Berkshire West, Uncle Bob, and Sussex. And I work very closely with Emma, who will introduce herself in a minute, I'm sure.
Perfect, thank you. I grew up in Buckinghamshire, so part of your Bob collection. Emma. Thank you.
Good morning all, I'm Emma Wilton. I work very closely with Simon, so I work for Health Education England across the South East. My role is a workforce transformation lead, and as Simon explained, we primarily face an ICS, so my ICS is the Sussex Health and Care Partnership.
Fabulous, thank you for coming. Nicola?
I'm Nicola Kent. I work with Catherine at the Northern Care Alliance and wholly new to workforce transformation. So just learning a lot this week.
Fabulous. So there's a theme here. The transformation is the theme, isn't it? So I think we're all trying to transform everything all at the same time, which is a little bit of a challenge. Is there anybody else who hasn't had the opportunity to introduce themselves?
Yeah, we've got Emily Cartwright.
Can everyone hear me?
Yeah.
I'm having some troubles with my laptop this morning. I'm Emily. I am also working in transformation, and I'm a graduate, very new to the NHS a couple of months ago. So yeah, I'm working in the transformation team in Dorset County Hospital down south, and similar to some of the people, I'm getting very involved in the new ICSs and ICB style things. So that's me.
Welcome, thank you.
And then we also have Tina Hansen.
Hi, sorry, I'm not having to navigate both unmuting myself and putting the video back on. That's just too complicated.
This whole exercise is just to demonstrate.
I know, it's like, yeah, it's
no other reason.
Testing, yeah, but look at my background. You know, I've got the clear background. I was worried you're going to see my messy background. Anyway, nice to see you all. So I am part of 33N and I'm part of the team that supports CLEAR, and specifically within my remit is to look at what CLEAR does and help sort of think about how we can stretch and refine and expand what we do to have sort of greater impact and, you know, basically make things better for patients generally. Probably enough about me.
No, that's great. Thanks, Tina. And I think, is that everybody? Yeah, perfect. Thank you. So yeah, that was just a test to see if everybody could come off of mute and go onto a camera. So that's about it, I think. It's great to see everybody here. And I think really, I'm going to share my screen in just a second and go through a bit of a presentation. But I do want you to sort of put your hand up and ask any questions as I go along. The approach that I'm going to take is one where I want to sort of tell a story. I want to really think about what I've learnt along the journey over the last sort of 18 months. And I think through storytelling, generally, I make meaning and understand and reflect and think about what has supported the programme and the team and myself individually, and taking some of that learning forward into sort of the different programmes that we're now working with and through. So it's really helpful to start with the beginning and the London Transformation Learning Collaborative. So the Learning Collaborative was really born out of necessity, and that necessity was something that probably all of us should recognise, which is COVID-19. And as the pandemic struck, there was a real challenge, as we know, within our NHS services, and particularly around critical care and enhanced care areas. What we found very quickly, it wasn't just around the bed spaces and the actual environment, but actually we didn't have the staff that we needed. The workforce was being stretched to meet the demand. We created a sort of a review of what was happening, what was the context that we were working in, because it's so important for us to really understand the landscape, to diagnose what the real issues are. And we looked at it in terms of sort of a driver diagram and a bit of a domino effect. And what we saw was that there was an insufficient supply of staff. There weren't enough key professional groups certainly within critical care. We saw that within nursing and anaesthesia. There was an over-reliance on agency and bank to fill those vacancies that existed. And what we had was a really poor visibility of the existing workforce. Yes, we have ESR data, but we didn't really have a really good understanding of what the skills and capabilities of our workforce were. We also had a limited or unachievable workforce model planning. So when we were looking at sort of going into that second surge and preparing, we're in a position where we were having to continue with elective surgeries, with elective cases, which meant that we had limited time to really think about how we were going to plan for the future. There wasn't really a consensus on what the new ways of working should be, what the new workforce model should be. And there's also thinking about the traditional role boundaries and the sort of the ideas of what any particular person or group, professional group, could do within a critical care. There was no real consensus about that. We also knew that a lot of the guidance that came from the national bodies was fairly late in the day. That made people feel uncomfortable to move outside of their usual professional roles and their professional accountabilities. And there was some stress and anxiety about what the implications might be for those individuals. This led also then to a lack of staff release. So staff weren't being identified for deployment because nobody knew what types of roles were needed and where those roles should be. There was also lack of understanding of people's willingness to be deployed and really understanding the well-being of staff and the feelings that they were having at the time in relation to being asked to work in different areas. and we didn't have really clear processes. So how was someone to be deployed? What were the HR processes that were going to be needed? And how do we get people to be where they needed to be very quickly? This then led to insufficient training and induction. So even though we know that there is a lot of training that's available, people were not necessarily having the opportunity to access it. They weren't identified to be deployed, so therefore didn't know which training they needed. And also there was a burden on our educators who were being pulled back into clinical practice to be able to actually undertake this training for the numbers of people that were going to be required. And also the supervision and the supernumerary in practice. So if someone moves into a new clinical area, they need to have some supervision, they need to have some support, and that wasn't always readily available. So this is the kind of landscape that we're working in. And I focus very much on the landscape in terms of the clinical activity and sort of our work. Never mind what was happening in everyone's personal lives, and recognizing the ambiguity, the different restrictions that were in place, and the different challenges that people were having in their home life around sickness, around childcare, and multiple other strains and stresses that people were under. So we had to consider all of these things as we moved into sort of what we call a recovery phase within London. So after the first pandemic, there was clearly defined a real issue. It was recognised that there was a real problem with workforce because of all of those things that I've just identified. It was recognised that there was probably going to be a second surge, and that there was going to be another increase in demand within enhanced care, critical care within our NHS. And we needed to plan for that. And so NHSEI and HEE together were working, certainly within London and I know within the other regions, to look at how could we prepare our workforce, our NHS, to be able to better manage a second surge. We were asked to pull together a plan to look specifically at education and training, and to look at how we could broaden the skill base of the NHS workforce, and how we could do that not just to support our patients, but also to support our workforce. Well-being and psychological safety was a key element. So we were commissioned by them to undertake a piece of work, and this was in July of 2020, and we really saw that we had only a few months to put into practice something that was going to be able to have an impact by the autumn of that same year. So what was born was something called the London Transformation and Learning Collaborative. And really, I'm going to talk a little bit about what our processes were, not just what the outcome was. I think that to really understand sort of transformation, innovation, or impact, we need to understand, like I said, that journey and the processes that we went through to be able to deliver and to be able to have sort of tangible outcomes or outputs. So really, how do we turn an idea into a social movement? If we're calling ourselves a collaborative, how are we going to make sure that the idea that we have, which may have been in a boardroom, which may have been just a small group of people, can actually be spread, can be adapted and adopted across London? And this was something that we really did think about. And something I've reflected upon is that I'm not sure if anyone has ever come across Simon Sinek. I'm sure you probably have, but certainly someone to have a look at. The approach that we really took was following this idea of the golden circle. And it's really starting with your why. And Simon Sinek talks very much about your why being your purpose, your motivation, sort of what do we believe? Why are we doing this? And if we can communicate that with others, then you're more likely to get people to come on board. You're more likely to get people motivated and feel aligned to your cause. Then once you understand your why, you can then move to your how. So this is where your processes and any of your actions or activities that you undertake to actually achieve your why. So it's always coming back to your why. And we really did utilize this approach. We really wanted to think about, why are we doing this? What's important to us as a team when we came together? What is it that when we're told no, when we're given negative feedback, that's going to keep us going and keep us on track and keep us motivated? And what is it that we're going to use to continually check in on ourselves that we're doing the right thing? So that we know then that what we do is really what's needed and is really going to have that impact that we need. So I really like this idea of the golden circle, always starting with your why, which Tina, you did very well when you introduced yourself and said your why to improve things for patients. And that's really what's going to get people to come on your journey with you and to engage and interact with you. So I'm going to go through the program in this concept of the golden circle and really start with the why, our purpose. So we did get the team together. We really did sort of talk it through. Why are we here? We've got a burning platform. We know what our burning platform is COVID. We know that we have to act quickly. There's a sense of urgency. We don't have time to spend a lot of time creating a perfect item. We need to really get going and move fast. So between us, there are lots of things that sort of were shared, and a lot of those things kept coming to the outputs. But fundamentally, what we wanted to do was we wanted to really think differently. We knew we couldn't think in the same way. We didn't have that luxury, but we really need to think differently so that we could appropriately support our colleagues. And the real key for us was around the psychological support, as well as the clinical impact in terms of making sure people felt safe to work and that we improved their lived experience, so that we didn't see staff go through the same sort of challenges and issues that we had in the first surge. There were things that we needed to learn and understand from that first surge so that we could improve things for staff moving forward. So we all got behind this common purpose, and this was something that we consistently drew ourselves back to if we felt that we were sort of started to go down a different rabbit hole or a different path, and just really bringing ourselves back to why is it that we're doing this? And it was about improving things for staff, so they felt psychologically safe and clinically safe to practice. And I say all staff and all colleagues, because we didn't just talk about it in terms of staff. A lot of us were clinicians, so we saw people as our colleagues, as our friends. So how did we improve it for all? And this is multi-professional, not just nurses, not just AHPs. We saw this as a whole workforce issue that we needed to be working with. When we went from our how, it was then thinking about our why. So we then went to sort of, well, how are we going to do this? What's the processes that we're going to undertake? What's important to us? And the approach we really wanted to undertake was really to understand the new models of care. Things had changed because of COVID. We couldn't work in the same way. So how were people now working? What are the new models of care? If we've got a new model of care, we also need to think about new models of workforce. They go hand in hand. So if we're adapting the model of care, then how do we need to adapt our workforce? Or if we're not adapting our model of care, how could we adapt our workforce to meet the needs of what that model of care needed to be? So really understanding the workforce who was available, and understanding how we could adapt or enhance some of the skills that the workforce had to meet this new model of care. And once we have identified those things, you can then really understand that level of education or training that people might need to be able to deliver that care safely. And again, it's going back to enabling staff to reach their potential, enabling them to have the skills and capabilities that they need in the conditions that are working, to feel safe to practice, and to actually want to go to work, to feel safe to go into work. So we had an ambition to support the cross-skilling of the NHS workforce. We wanted to ensure, processes-wise, that the training infrastructure could adapt to the surge in activity and the current critical care capacity. We wanted to ensure that well-being was integrated and thread through everything that we did, and that there were opportunities for workforce and training innovations. So we recognised where those innovations were and making sure that they were adopted and spread at pace. So everything was about being rapid and at pace. The other how in terms of process was that we needed to work out loud. Like I say, we didn't have a luxury of time. And so what we needed to do was to come up with something, and we needed to make that work visible, and we needed to make it visible very quickly. We wanted to make sure people knew what we were doing, felt that they were involved, could collaborate, could co-design and co-develop with us. And the only way to do that is putting yourself out there. That's quite challenging. That takes some courage. I think certainly as healthcare professionals or as professionals, you're used to having something that has gone through many different iterations before you expose it to the masses. But we didn't have that time or that luxury. We also had to build relationships very quickly. We had to be generous with the work. So offer something to people rather than, like I say, holding something to ourselves until it was perfect. But we also then had to make sure that we were purposeful in terms of really understanding what people's needs are, what they wanted. And we had to be able to then take that feedback and be able to put it into practice quite quickly. So I like this idea of these 5 elements, and I really do think that these are the processes that we went through. We very quickly shared our work. We utilised e-learning for health platform, and we put it up there. We asked people for feedback, we consulted, we went out to multiple networks, built relationships and spoke to people. We let people know what we had. We were very transparent, we were very open. We told people what we did know, what we didn't know. And we made sure that we went out and asked questions. And that when we took that feedback, that we actually did something with it. So I think ensuring that you are able to have those mechanisms and processes in place to support this way of working is really key. So how did we do this? How did we work out loud? We had focus groups, we did surveys, and we had groups that we formed within each of the integrated care systems, which we called our Pan delivery and assurance groups, and we had one Pan London overarching group as well. What was really important about these groups was that they created the networks to be able to understand from people on the front line, to understand from clinicians that were working in practice. We involved the multi-professional team, so we have HR, we had clinical leads, we had educationalists, and like I said, it was multi-professional or interprofessional, so we ensured that we had pharmacy, AHPs, medical, nursing. Everybody had a seat at the table and had a voice and needed to be heard, because this was going to be, as we'd seen in the first surge, we knew that this is only going to be managed as we acted as one, as a team, not within our professional silos, and we needed to understand each other. So it was a really important mechanism also to use these integrated care system groups to then feed up into a Pan London group. This could then make sure that the issues and the challenges that were coming from the clinical area will be taken all the way up to the executive team, to our executive gold command. And it was really a fantastic conduit between our executive teams and those working clinically. And that was something that was really fed back, was that they felt that they would be heard, that they'd actually had an opportunity to say what they felt, and not only was the opportunity there to say this, they were listened to and responded in a way that they felt respected. The other work we did was with Clear, so deep dive sites in a couple of the ICUs. So really understanding using data, both from a patient and workforce level, and sort of that quantitative data, but also the qualitative data. So understanding the experiences of individuals and bringing that to the forefront. And we also use research using UCL, which is a rapid qualitative research, interviewing people again to understand what their perspective was, what their lived reality was, and what they felt that they actually needed, so that we're not designing something that is through the lens of one or two people, but is through the lens of a system. So doing this means that you have to also have opportunities for continuous feedback and learning. This takes some courage to have multiple stakeholders have an opinion is something that you have to be prepared for, and you have to support your team to enable them to be able to receive that feedback, to be able to process it appropriately and respond to it appropriately. We had some people who loved the idea of working with the LTLC and loved the idea of creating educational resources that could be available to all. We had others who felt that they were getting on doing things absolutely fine themselves and really didn't want to be interfered with and couldn't understand why, when they're so busy, that we were trying to interfere with them. There were some that I would say possibly felt like they were trying to sabotage what we were doing. And that was challenging as well. And there were some people that just didn't want to, didn't feel that this was a positive thing, didn't want to engage with us. We had to recognize who all of these different stakeholders were. We had to make sure that each of these critics, supporters, cheerleaders, that everybody had a seat at the table, that everybody could be heard, and that we will be able to respond to them effectively. And sometimes that response was to say, thank you, we've heard you, but we are doing this anyway. So you can take on board sort of advice and information, but you can decide exactly how you're going to utilize that information and repeat that back to those individuals. So really important to ensure that we have that continuous feedback and learning mechanisms in place. One of the other key areas was around connectivity. So if we're looking at different ways that we want to be working, if we're looking at how education and training can support people, and we're looking at doing this across all different professions, then we need to make sure that we're engaging with vast amounts of people. So you can see over the life cycle of the programme that not only were we engaging with people within London and building the integrated care system, but we were also building relationships with our national colleagues and international colleagues as well. So if I want to, or if we want to look at a new role or a new way of working, then I need to make sure that I'm working with the British Association of Critical Care Nursing, the Intensive Care Society, with the RCN. So it's recognising that any of the changes that you might want to make has an impact on others, and others will have an opinion. And it is better to go out to the system to understand exactly what their thoughts are, and to start a dialogue with them and to work with them, and to see really that you're not trying to be a threat to anybody. But connectivity and keeping people informed and understanding who needs to be part of the decision making was also key to us be able to develop any of these resources or any of these kind of sort of e-learning pieces was going to be key, and really to ensure that those that were going to utilise them felt safe to do so. So what has been created? So we went through a process of understanding why, we understood the context, we listened really to what people felt they needed, what was important to them. We made sure that we connected to the appropriate bodies to get their support and engagement, so that when it came to the implementation, that those who were implementing felt supported and enabled to do that. One of the first things that we did was to create the microsite, and we have around 600 open access resources on there, and those have been launched, as you can see, over 110,000 times. We were a winner of the Intensive Care Society Education Awards, which is fantastic. Within that site, we created an interprofessional skills matrix, so it's sort of around competency-based roles and tasks, and then the aligned education or training related to those. We curated resources. We recognised that there were a lot of training materials that were out there. We wanted to recognise those, put those onto a platform that people could access, and made sure that those individuals or those trusts or groups' IP was recognised and they were recognised for that work. There were gaps, though, that were identified, so we developed training materials with different groups where there were gaps, and one of those gaps was around understanding the environment that people are going to be working in, so we created the 360 virtual reality, both for staff and then ICU steps, so patients and survivors got in touch and said that they felt this would be important for them, certainly as the families weren't going to be able to visit during these COVID times. We also made sure that there was face-to-face virtual training, so that had been identified that it's great to have e-learning, but we actually need some face-to-face training as well. So that was commissioned and delivered between sort of the September up until the January, February of the following year. The other thing that we developed, which was identified by the system, is that there was no real record of people's skills and capabilities. We created 2 new roles that were outside of the establishment, which is the non-registered support staff and the registered support clinicians. So those staff members did not have a standard sort of role definition. There was no real clarity on what types of education and training they required, and there was no real way of documenting that they existed in the skills that they'd established during the first surge. So we created a digital platform that was for the learner, so they had a way of documenting what they'd undertaken, but it also meant that a trust could actually see exactly what and who had undertaken the training, so that they could deploy from a sort of workforce planning perspective. So the other thing in terms of the what is the legacy. And so what's really important and has been important to us as a programme is that this isn't just about that we were commissioned to deliver a programme over a set period of time and then you close and that's it. It's understanding how do we continue to support our systems. The microsite remains. The microsite is now actually available internationally. So many other countries are accessing those resources as well as they go through their COVID surges at different times. There's a rollout of the Digital Skills Passport, which is now national. So it was a London initiative. So now we have an early adopter programme across the country. We've been commissioned to undertake other programmes, such as the Respiratory Surgery in Children and also a CYP and mental health programme. Some of the other legacy is about the learning about how you create rapid education materials and sort of the whole process of how and the methods in which the LTLC used to enable us to diagnose, create and integrate at such pace. And I think one of the really key elements has been around the creation of those networks and strengthening of the system connections, bringing people together, connecting people, ensuring that everyone has sight is a really important part. And often we talk about the tangible outputs, such as a website, such as a digital platform, but we don't actually talk about the relationships and the connections that have been made that are really now supporting people as they move forward as well. And then obviously we hope that we've expanded the skills of our staff and really have achieved what our why was, which is making sure that people feel more safe to practice, both psychologically and clinically, and that this has been seen to be a support to all members of the workforce, not just medical or nursing, which are often just highlighted. So that's sort of our whys and our how and our what, and the journey that we went on, and sort of reflecting on some of those things. Really, some of the sort of key learning and recommendations for any of you that are going through this transformation yourself at the moment is that people are the key. We can talk about processes, we can talk about systems. It's people that create those systems, and it's people that create those processes. So unless we get people on board with us and understand what their issues or challenges are, and try to create an innovation or a transformation that actually meets their needs, they're not going to embrace it, and they're not going to implement it, and sort of buy in and take it forward. So really recognizing the cultural norms of a system and organization, and how that can impact your sort of spread and pace of change that you're trying to implement. Complexity. We work in a really complex system, and sometimes we just keep looking at simple solutions. I would suggest that there are many that probably thought that the LTLC was a simple solution. Let's just provide a load of education for people. When you look at the driver diagram that demonstrated at the beginning, you can see that it was so complex. And actually education, the delivery of education came right at the bottom. And until we understood all of those other causes and drivers, then having a beautiful package that sits, educational training package that sits on an e-learning platform is not really going to have the impact that we need. So recognizing the complexity, not just looking for simple solutions, and there's not going to be one solution, it's going to be multiple. And we need to make sure that's understood and articulated. Education teams can't operate in silos. Again, we need to collaborate with workforce and clinical teams. It's not something that is just a nice to do at the end of the day. And it is actually what is going to motivate your workforce, develop your workforce, and ensure that they're in a position to work safely. Also, really recognizing if we're asking people to extend their scope, making sure that there is real clarity about what that means. There needs to be a bit of a cultural shift. There will be barriers to it. So how do you work with people to understand the reasons why, and support them to understand and to be able to utilize their teams and their colleagues in different ways? Funding is a big issue. We had investment for this program, and there's a lot of investment coming to the NHS right now. We're all hearing consistently how many billions, and that's very difficult to spend within the timeframes that we have with an exhausted workforce. So we need to think about funding models that which really support our workforce over a long period of time. And as the complexity of patients change, we need to think about how those funding models change, and recognise that this needs to be across the workforce. We recognise that there is obviously a high volume of funding that has been identified for our medical training, but we need to see the same levels of funding available for other professional groups and the multi-professional teams. And ultimately, staff need time and space and notice so that they can actually identify the training that they want to undertake, be given the opportunity to undertake that training, and have the opportunity to then implement that into practice and have the support and supervision to do that. And what's key here also is our educators, our trainers, making sure that they are also given the amount of time and recognition and are valued because of the tasks that they are having to undertake right now to support multiple members of their teams. So these are some of our key learning, but ultimately I would say that the why is key to any success of your transformation, and remembering that people are at the center of everything that we do, and we need to work collectively to be able to achieve many of the ambitions that that we all have, certainly with transformation in many of our titles. I really liked this sort of insight, I would say, from Margaret Wheatley. So I'm going to give you a minute to read it and let you reflect on it for yourselves. Okay. People can say things so more, articulate things in a lot better way than I can. So to leave you on that quote and say thank you for listening. And if there are any sort of comments or questions right now, but in future, then please do be in contact. I'd be more than happy to have a conversation.
Thank you, Julie. Any questions from the audience?
Not so much a question, but more of an acknowledgement of one of the problems we're trying to get your workforce to be effective or get the most out of your workforce. And we look at ESR, and there seems to be, I've been working in the NHS for about 4 years now, and there seems to be this a certain amount of apathy about changing ESR. Oh, it's great, you know, it's much better than where we were before 2008 when it was introduced. Yes, but we don't just stop. We need to continue that development. I'm ex-forces by background, and we went through a process around about the same time, actually, of sweeping out about 70 odd legacy systems across the 3 services and introducing a new tri-service version of ESR. We call it JPAS, Joint Personnel Administration System. The problem with ESR is, as Julie illustrated, as a workforce planner, I can see people's professions, but I cannot see their skill sets. And that is really hampering my ability to try and advise, influence, and everything else, that change. And I often get asked questions like, how many cancer nurses do we have? And Emma's probably listening and rolling her eyes to the ceiling because I often quote this. And I'm rapidly approaching 60, so therefore I have license to be grumpy. And if I'm grumpy, I'll turn around and say, we don't have any. I usually get a surprised look. We don't have cancer nurses, but adult nurses, children nurses, learning disability nurses, and mental health nurses. Some of those probably more adult and children nurses, although maybe some mental health nurses as well, specialize in the delivery of cancer care. And that's what I would call an additional qualification. And in the military, we had that. We had a field which called AdQuals. Here you might look at it as job role, but the problem with job role, and every single field in ESR, it's a single value field. And all of those extra qualifications that people pick up along the way, I cannot see. I used to be able to in the old role, but I can't here. So for me, if you wanted a step change in how we look after our workforce, and how we make them more effective. And it would be retention positive as well, because at a flick of a switch, you could see the skill sets within your team, particularly operational service managers, trying to get the best out of them. Who needs this training? Who would benefit, et cetera, and really manage those people well. We need an update to ESR. And I know there are some rumblings that the time is right to perhaps have a new system. But that would be the single most important thing for me, to be able to see those additional skills. Endoscopy is another one. How many endoscopists do we have, Simon? We don't. we don't employ endoscopists. We employ people who can carry out that procedure, but there is no profession of endoscopy. Gastroenterologists will be trained in it, some senior nurses and some diagnostic radiographers sitting at the top of their license as well will be trained in that procedure, but I can't see that, and it's really frustrating.
Simon, I feel like I'm having the same dialogue. So what has really highlighted through COVID is the fact that we do not have sites, as you just described, and that the system that we currently have is not fit for purpose for what we're requiring. So those are the conversations actually that I'm having actively, and really pushing NHSEI and HEE together. And part of that is also that what we're going to end up with is a lot of different
different systems bubbling up in the different regions, which is just going to we'll go backwards rather than forwards. Somebody needs to grasp this nettle and really bring something in. I already know that things like sickness and absence, often at trust level, is managed on a separate system and then feeds into ESR. We now, as the time is definitely right to reinvigorate ESR, either have a bolt on something to it or have a completely new system, because there's a lot of mistrust in ESR as well at trust level. It doesn't do what it's meant to do, and it doesn't help operational management. It helps strategic management, yes, sitting where I sit, but the operational, the day-to-day management of your staff, and making your staff flexible and nimble and empowering them to react quickly and effectively to emerging situations like COVID, it doesn't support that.
No, and it didn't. And I think we have, that's what sort of we have a really good case right now that says that we were not able to efficiently, effectively
re-roll the workforce into another format, another shape. And we used to go through this a lot in the military. Prior to any deployment out to any theatre of operations, you'll take a normal, my background is Royal Marines, so you take a commander unit, it normally has a set shape, but when you go into a new theatre of operations that isn't amphibious warfare, you have to re-roll it and reshape it. And the systems we had allowed for that, but we don't have that capability within the NHS. And COVID has given us a really good opportunity. Good's probably not the right word, but an obvious opportunity where we've tested the system and it doesn't work.
It doesn't work. And that's those are the discussions that I'm consistently having. And so the other argument that I have is the well-being of staff. I mean, obviously we use the word well-being quite a lot now, but by not understanding people's skill sets and confidence to work in certain areas, we've put them into hostile environments, which has caused harm. So if we truly are behind the rhetoric of well-being, then this is another way for us to support our staff. So yeah, that's a big argument that I'm consistently having at the moment. And we were another example of bringing in an external provider, Axia, to do this skills passport, because the system, when I requested it, couldn't actually do it for us.
It's impossible.
So we've had to go to an external provider, but that's again part of my argument as to if we have a long-term plan. And we have the people plan that talks about the digital first, then how are we actually demonstrating that and role modeling that on a daily basis?
I've seen Catherine's also come off mute. You have a little question, Catherine?
Well, yeah, no, it was. I was just going to ask Julie, but I think she's already sort of basically answered it. What difficulties were there in trying to see the workforce across such a large area? And obviously you've described that really.
We couldn't, and so we had to create something very quickly to try and resolve that. And I say that we put a lot of mitigate, because people were saying, oh, it's a solution. I said, there are no solutions, these are all mitigations. So I change my language quite a lot and never say that I ever have a solution. So these are all just we're all just doing some mitigations right now to try and reduce the impact. And but yeah, I think the visibility of staff is really key, and that's been something that, at least with the passport for the non-registered support staff and registered support clinicians, we have cited those now, but it's a big issue across the NHS as a whole, and certainly with the recovery. Again, being asked questions around cancer nurses, endoscopy, all of those areas, the questions are coming in about how many do we have, because we're trying to do the right thing to say, well, how many do we have, and your baseline, so therefore how many do we need, so we can focus the training or the development or recruitment, but that data is very difficult to come by, and it's reliant on a manual process, not number of Excel sheets that I've seen flying around is ridiculous. So this is, for me, one of the number one priorities is around this, recognizing that it's not just a band and a role title that we need for coding, but we actually need a recognition of people's capability and qualification or skill.
I had to look up how many job titles in ESR we have under admin and clerical band 4 yesterday. I won't bore you with why I had to do that, but there were 132 job titles in Salford Royal alone for people in admin. I mean, and that's because, with the limitations of ESR, it doesn't force people to pick a certain role title.
Yeah.
You can just put anything you want virtually.
And it's been
don't get me on my soapbox, please don't. And the tertiary area of work as well, there are over 320 different tertiary areas of work that I can see in the South alone. There isn't a single trust that uses all of them. There are no two trusts that are set up the same way. So I mean, the exercise we had was, right, Simon, I need to look at the imaging workforce. Can you put that together? So, okay, fine, we'll look at imaging as the tertiary area of work, we'll bring everybody in. But what that did was it illustrated the differences in how all those different trusts set up their staff and are constructed physically on the ground. It's different. And for a military man, it's a complete anathema because you can't manage it on a grand scale because you're all different. Yeah. So we had, in the South, we have got about 2,300 diagnostic radiographers. There are only about 550 sitting in tertiary work of imaging. The largest group was actually in clinical radiology. Say that they were missed in that way, but somebody somewhere was forcing me, no, that we must have a catch. So I said, it doesn't exist. If you really want to understand the whole imaging workforce, you're going to have to approach each and every single trust and ask them to fill out a form. And you know what? That's more data gathering. They're already fed up because of COVID. And the annual planning round anyway, and all the other returns they have to do, they're just going to stick two fingers up at you. So we need to be clever about how we deliver this. And what was the other thing I was going to state with that? Oh, come back to me. There was something else. When I was actually dealing with a trust, they said, Simon, why is it when we look at the templates that are sent out from the centre, NHSE and I, on the operational planning round, why do you put your staff groups together differently to the way they are in our trust? I said, right, that's easy. It's a very easy question to answer. In the South, and this is before we were split into 7 regions, this is when HEU was 4 regions and the whole of the South was together, not South East and South West. There are 55 trusts across the South and no 2 trusts are alike. So liken that to languages and going to an international conference, either you ask me to learn 54 other languages or you all learn 1 extra language. And that's why we do it. You will align to 1 template so we can then compare like with like. So if you don't want to do it, then pick a model hospital. There's a clue. And all align, but that's never going to happen. But at least what I'm trying to do in one of the systems at the moment is to get consistent use of ESR, not rearrange the hospital, but at least a naming convention within your position title, and at least get the system working together, and then hopefully we can spread that out across the region. But it's, I pull my hair out. I've got little enough left as it is, but yeah.
But it's the, again, it's that productivity, isn't it? And the amount of time people are spending on these sort of manual processes and workarounds is really what we're talking about, isn't it? And so it is making sure that we can actually have a comprehensive case that we can make sure that NHSEI and HEE are working together to resolve the issue, because it will make the organisations themselves in a better position as well.
And if we're looking at systems, you know, it goes even wider than NHS, obviously, doesn't it?
Yeah, absolutely.
NHS organisations, it's your social care, third sector, the care sector. It's, if we're really going to see what's of our assets across all of a whole system, it's even more complex than that, isn't it?
Yeah, absolutely.
It is. We went through, and I'm going to have to go in a minute because we've got 2 minutes silence. But we looked at modelling the whole workforce, so bringing alongside the ESR data, primary care data, and social care data, and children's social care data, which is in yet another format. And we just use ESR as the most comprehensive set of data, and we just literally cut and paste all of that data underneath the equivalent columns within ESR in an Excel spreadsheet, and then we built some tools from that. So we could just quickly, right, I want to see the whole workforce in that system or in that CCG, we could do it. And that's how we got around that one. But it took a lot of work to transfer that data across, put it in the right columns.
That work around again. We will continue to fight as a collective.
That was really interesting, Julie, your presentation. Thank you.
Thank you very much. I'm going to have to go, people.
A pleasure.
Nice to meet you all. Bye-bye.
Thank you. Bye-bye.